afternoon, everyone. My name is Ayuko Iverson. I'm one of the clinical geneticists and internists in the Department of Genetics and Genomic Sciences, and I'm very happy today to be speaking with you about genetics for the adult primary care provider. So my talk today is part of a specialty webinar series that's being hosted by my department in genetics. And just a couple of housekeeping issues to talk about before I begin. If you have any questions that come up, please feel free to enter them into the chat box below. I will be holding questions until the very end. And also in the same chat box, feel free to suggest any topics for future webinars that you may be interested in or to provide specific feedback. As you are probably aware, we have had a couple of these talks already. And we have a couple more planned for you, including one that's coming up on November 19th that will be done by my colleague, Dr. Cassie Mintz, and she'll be speaking about common pediatric referrals to medical genetics. I have no conflicts of interest to report. So just a brief overview about what I'm going to be speaking about today. I'm going to be talking about a brief overview on a background on genetics, how to recognize genetic conditions, when to refer your patient to a genetic specialist, common referral indications, options for genetic testing and how to interpret these results, and then a couple of interesting cases that I've come across. So as you are probably all very, very well aware, there is a wealth of information that can be gleaned from an individual's genetic information. For one, you can diagnose them with a genetic disorder. You can see if they have any susceptibility to a specific disease. You can see if they're a carrier for a genetic condition. And you can see if they may or may not respond to specific drugs when it comes to pharmacogenomics. So if you combine this genetic information with other health information, we are able to provide tailored care to an individual patient. This is what we call precision medicine. You know, this is of course something that we all do as providers on a day-to-day basis, but genetics and genetic medicine really allows us to do this. And our goal is to provide clinical outcomes and to minimize unnecessary diagnostic and therapeutic interventions. So knowledge in genetic medicine is really important for both primary care providers and specialists. You've probably had the experience of a patient during their visit with you talking about a family history that might be really concerning to them or a personal family history, and they ask you, is this something genetic? Is this something that I've inherited from my family members? And so having a basic knowledge helps you as the provider to educate and counsel patients. And also it's important for informed consent. So I'll be talking about this in more detail later, but before any genetic testing is done, we always consent the patient, and so it's important that the patient know, the benefits and also the limitations of genetic testing. And then finally, again, going back to the precision medicine point, having a diagnosis for your patient allows you to provide evidence-based treatment and institute appropriate surveillance and follow-up. And if needed, refer to a genetic specialist if they need further workup or to other subspecialists. So there are a couple of key things when it comes to recognizing genetic conditions. As you can see here, these are things that you already do on a day-to-day basis with your patients. The first is obtaining a medical history. The second is doing a very thorough physical exam. And in genetics in particular, we do something called dysmorphology, which is where we look at a patient's, very closely at a patient's physical features to see if it points to a specific diagnosis. And I'll give you an example in a moment about that. The next is family history. We spend a lot of time obtaining usually 3 to 4 generations of a patient's family history. We obtain each of the patient's relatives' medical diagnoses, what age they were when they received those diagnoses, and we draw out a pedigree, and that allows us to visualize possible hereditary disorders and their inheritance patterns. So here's an example of a dysmorphology exam. So we actually have the same patient here at 3 different time points in his life, age 4.5, age 18, and age 37. And you can see some of his facial features become more prominent over time. So you see he has an elongated face, he has a broad forehead, and he has prominent large ears. And if we look into his history, we can see that as a young child, he presented with developmental delay, and as an adolescent and adult, he now has mild to moderate cognitive impairment. He was also diagnosed with ADD and anxiety, and on exam, in addition to his facial features, he has pes planus and macroorchidism. And so if you put all of those things together, it points to a clinical diagnosis of Fragile X, which of course we can confirm with genetic testing. So when it comes to family history, 96% of Americans, so most Americans, know that their family history is important to their health, and yet a small fraction of them have tried to gather and organize this health history. And you're asking, why is it important to gather this history? And as I mentioned before, it helps us determine hereditary disorders and determine inheritance patterns, but it also helps us to identify individuals who possibly are at risk and those who are not for inheriting a possible genetic condition. So again, the question is, why is it important? Why is it important for us to identify and diagnose patients with a genetic condition if they have one? And again, it comes down to the personalized medicine that I mentioned in my first slide. In genetics, we're able to really provide patients with personalized therapy, a disease-directed therapy. And we have treatments that are available at the gene level all the way to the organ level, the clinical phenotype level. So, for example, we have, there are gene therapies that are now clinically available. There are RNAi therapeutics that help, that degrade defective mRNA. One good example of this is mRNA therapy for TTR amyloidosis. There's also enzyme replacement infusions. This is, we use this in particular with lysosomal storage diseases like Fabry and Gaucher. There's also dietary interventions that we can do for our metabolic patients. A good example of this is PKU, where we monitor how much protein they're intaking. And then finally, things like medical and surgical interventions. So a lot of our metabolic patients will have kidney or liver transplants that really helps manage their disease and really improves their quality of life. And then finally, as you can imagine, genetics doesn't affect one individual. When we diagnose someone with a genetic condition, it has implications for their parents, their siblings, their children, etc. So after we diagnose an individual with a condition, we oftentimes will do cascade testing, we'll test their family members so that those individuals can get the appropriate management and testing and surveillance as needed. So this is a question I often get from my colleagues. They ask me, does my patient require or need a genetics workup? And 100% of the time, my answer is always yes. I think that providers in general have a very good sense of what patients require genetics workup, but I wanted to highlight some of those here. So the first is patients with clinical findings that are indicative of a specific monogenic syndrome or disorder. So for example, polycystic kidney disease, polyps, multiple polyps in a colonoscopy, etc. Those patients should be referred. The second are patients with early disease onset with a strongly positive family history. And what I mean by early disease onset is something that is atypical for that particular condition. So perhaps it's renal disease in a 30-year-old, or an MI in someone who's 40 years old without any other risk factors, and perhaps have had multiple family members with those same issues. Those are patients that should be referred to genetics. Third, and I think this is the one that I really want to highlight because it's probably not as apparent to providers, but it's patients with either really rare disorders or common disorders that are unexplained after an unrevealing standard diagnostic workup. So you can think of someone perhaps who is 50 and had a stroke, and there's really no explanation as to why they've had their stroke, or their renal disease, and they have no other underlying conditions, even though they're older. Those are patients that should be referred to us, to medical genetics. The fourth is healthy individuals with a family history of disease for which early diagnosis would allow preventative intervention, so things like sudden cardiac death or perhaps a hereditary cancer syndrome. Patients with a rare condition that has an established genetic predisposition, so like severe hyperlipidemia or long QT syndrome. And then when it comes to the OB/GYN realm, patients or couples that are preparing to conceive, whose ethnicities have a higher carrier frequency for specific disorders, such as Ashkenazi Jewish population, or couples who are consanguineous. So I wanted to give you a few concrete examples of common referrals. I'm not going to go through all of these in detail, but I just wanted to highlight some of them for you. So things like a progressive neurological condition, like early onset dementia or progressive ataxia, or early onset hearing loss. Those are all indications or findings that would warrant a genetics workup. So another question I oftentimes field is questions about hereditary cancer syndromes. And there's a couple of red flags to look out for when you're speaking with a patient and obtaining their family history when it comes to cancer that should put up red flags for you about a possible cancer syndrome in the family. The first is multiple cancers, either in your patient or in first-degree family members. The second is a young cancer, so a breast or a colon cancer that are diagnosed under 50 years old. The third is rare cancers like male breast cancer, and then sometimes ancestry, like Ashkenazi Jewish ancestry, can also provide a clue. So here we see a classic BRCA2 pedigree. This individual right here is our proband. That's what the arrow is pointing to. This is your patient. And we can see that we actually see in this whole pedigree a couple of these signs that I already mentioned to you highlighted in this pedigree. The first is this proband's brother has a rare cancer, so male breast cancer. Then we see her deceased mother actually has multiple cancers, so both a breast and a pancreatic cancer, as well as a young cancer that was diagnosed, a breast cancer diagnosed at age 45. So if you put all of these together, including the grandfather's history of prostate cancer and the aunt's history of ovarian cancer, this points to a diagnosis of likely BRCA2, which again can be confirmed with genetic testing. I wanted to highlight a couple more things of when to consider hereditary breast cancer. In addition to some of the topics I already mentioned on the previous slide, if an individual has a personal history of triple negative breast cancer diagnosed at less than age 60 or younger, an individual who has 2 or more primary breast cancers, or if someone doesn't have a personal history of breast cancer but has a high suspicion of hereditary breast cancer in first or second degree relatives, such as the pedigree that I showed you earlier. So I'm not going to go into any more detail about cancer, but I just wanted to highlight that we've already had 2 talks done by Tahila and Julie, who are our cancer genetic counselors, and feel free to go to the Genetics and Genomic Sciences YouTube channel and you can watch their talks at your leisure. So switching now to steps in clinical genetic testing. After we've obtained a history and exam, got someone's pedigree, we think about what type of test we want to get. And we always take into consideration cost of the test and coverage, insurance coverage for the patient. And luckily, this can be a real big concern because, as you are aware, genetic testing can range into the thousands and thousands of dollars, but most insurance companies will cover some types of genetic testing, and we are, for the majority of the time, able to obtain coverage for testing that we think is appropriate for the patient. After we counsel and consent the patient on the testing, we send the sample to the laboratory where they process it and interpret the results for us. And I'm going to go into a little bit more detail about variant interpretation, how to look at genetic testing results. And then finally, we meet with the patient when their test results are back to talk about management and then testing for family members as indicated. So when it comes to testing strategy, ideally we would test the affected relatives. If you think back to that BRCA2 pedigree, you can imagine that if we tested our proband, that female patient that didn't have any personal history of cancer, if the testing came out negative, it would be uninformative because, obviously her family does have a hereditary cancer syndrome that's running in the family. Ideally, in that situation, it should be her brother or her aunt, for example, an affected family member that should have the testing, so that if a pathogenic variant is identified, then either a negative or a positive test will be informative in unaffected family members. So just like any other procedure that we do in clinical practice, genetic testing, I see it as no different. We always obtain informed consent prior to testing so that the patient understands the benefits and limitations of the test. One of the items that we focus particular attention on is possible test results. I think both patients and providers alike oftentimes see genetic testing as very black or white. Either you have a disease or you don't, or the test rules in a condition or rules out a condition. And many things in medicine, it's not black and white. There's actually the potential for uninformative results, which we call variants of uncertain significance. And these are results where we find a variant, we find a genetic variant that, with the state of our current genetic knowledge, we're just not able to classify it into either a positive or a negative result. And as you can imagine, sometimes this can be very difficult for patients. This can be a very difficult result for a patient when they're really searching for an answer. And at least at that time when we get the report, we're not able to determine whether or not a result is positive or negative. We also go into the limitations of testing, and one thing that is important to highlight is that genotype does not always equal phenotype. Especially if there's a condition that's running in the family, oftentimes patients will ask, if my test is positive, if I have this condition, will my disease look like my brother's, or will it look like my father's? And sometimes, the answer is yes, but other times we're not able to tell a patient if they will even show symptoms of a disorder, or how severe it is, or how progressive it is, because oftentimes the phenotype can vary even within a family. And we also talk about GINA, which is a law that was passed in 2008, which makes it illegal for health insurance providers as well as employers to use genetic information in decisions related to providing eligibility for insurance or eligibility for employment. But it's important to note that it does not apply to other forms of insurance, such as long-term care or life insurance. So once we do the history, we do the physical, we obtain a very detailed family history, and we've decided on our differential on what we think a patient may have. We then decide what type of testing to obtain. And as you can see here, we're very lucky now that we have a whole wealth of diagnostic genetic testing tools at our disposal. Some of them you probably remember from junior high school biology, which is the karyotype, which we still, it's been around for decades. We still use it on a regular basis. We also have FISH testing, which is right here in the middle. We have microarray testing. And then I would say what the workhorse is of genetic testing is next generation sequencing, which I'll speak about on the next slide. So when it comes to sequencing, you know, of course, if we have a very specific disorder in mind, a single gene disorder, we will order that single gene or 2 genes that are associated with a specific disorder. Oftentimes we do panel sequencing, which is a whole set of genes. It can be anywhere from, you know, 3 or 4 to hundreds. And these are genes that are selected by the genetic testing laboratory that are known to be involved in a particular condition. So an example of this would be a renal disease panel, which may have a dozen or so genes that are known to be related to nephrotic syndrome or FSGS, etc. And one of the caveats to this is that, number one, as I mentioned, it's selected by the company, the genetic testing company. So a renal disease panel in company A may be different, you know, may have some overlap with company B's, but they also have some differences as well. So this is important, you know, because to know in case that there's a specific gene that you were thinking of or wanted to make sure was covered in your testing. And of course, these need to be regularly updated as new disease-causing genes are discovered. So a panel that was done in now in 2020 may be very different or may have more genes added to it in 2025. So those are important things to keep in mind with panel sequencing. The next is exome sequencing, and I would say this has been clinically available for many years now, and has been, we're using it more and more. And this is where we don't just sequence a handful of genes or even, even a couple hundred, but we sequence all 20,000 genes, the exons of all the genes in someone's genome. And that ends up being about 1% of the genome. And this is helpful because it can identify variants in genes that are not suspected based on clinical presentation or is not yet known to cause a disease. But, as you can imagine, this is a very, very wide net. So there is the possibility of finding incidental findings. And this is basically diagnosing someone with a condition that's unrelated to the primary purpose of testing. So going back to renal disease, let's say someone who has presenting to you with renal disease at age of 30 and was referred to genetics, and the panel was negative. We decided to do an exome sequencing, and we always ask our patients about or counsel our patients on the possibility of incidental findings. So finding, for example, a BRCA1 or BRCA2 pathogenic variant in a patient with renal disease and otherwise has no personal or family history of cancer, we ask them if this is the kind of information that they want to know. And about 90% of the time, patients and families are interested in knowing this information and generally opt in for secondary findings. And the last, genetic testing, next generation sequencing test that's available that we don't really use on a clinical basis, but more is used in research settings is genome sequencing. But I wouldn't be surprised in the coming years that this will be used more and more in a clinical setting. So as I've alluded to many, many times, the challenge of not just next generation sequencing, but any type of genetic testing, like microarrays or karyotypes, is interpreting genetic variants. And this is because, patients can have variants that in known disease-causing genes that are just unique to them and actually may not even cause disease. And we just don't know whether or not, we don't have enough data to demonstrate whether or not that variant actually has any type of functional effect or a disease causing. So what we oftentimes, if we're not able to determine that, oftentimes we tell patients to come back in a year or 2 years when we may know more information or more data has been published so that we can look back into that variant, have the lab reanalyze it or look into the literature to see if that variant has been reclassified. So I wanted to give you the schematic of how variants are interpreted. So when you see a genetic test or a genetic test that has been ordered for your patient, you're going to be seeing three results, either uncertain, likely pathogenic, or pathogenic. If a variant is likely benign or benign, that will not be reported to you. But I really wanted to highlight that only pathogenic and likely pathogenic variants are clinically actionable, because we know with a high percentage of certainty that these variants are disease-causing. And again, this middle group, this uncertain group, are variants that we're not able to put in either one category or another. So I wanted to talk about three interesting cases of mine. The first one is a 24-year-old male who has intellectual disability and autism, and he had persistently elevated CK levels in the 20,000s, so very impressive CK level. And it was found during an extensive workup for asymptomatic transaminitis. So he had this transaminitis that was found when he was about 10 years old. He was initially seen by GI, had abdominal ultrasound, a liver biopsy, a lot of labs looking for autoimmune hepatitis, and most of the workup, all the workup was generally not diagnostic. And he was eventually also referred to rheumatology. In between them, someone obtained a CK level, which was found to be in the 20,000s, which would explain his transaminitis. And so he was eventually also referred to neurology, who did an EMG, which found generalized myopathy of the upper and lower extremities. So by the time we had seen him in his mid-20s, he had gone through this extensive workup already by his pediatric physicians, and was now being referred to see if we could figure out why he had this hyper-CKemia, and perhaps tie in why, if this was related to his intellectual disability and autism. So on exam, he did have some subtle but non-diagnostic dysmorphic features. He was macrocephalic. He was hyperteloric, had a broad forehead, wide nasal root and bridge, and also flat facies. On his neuro exam, he had difficulty with walking on his heels and his toes, but his strength and reflexes were otherwise normal throughout, and he had no calf hypertrophy. On his family history, he had a older maternal half-sister with a learning disability, but otherwise his family history was unremarkable for any other individuals with a similar condition. And at that point, based on his history and our exam, the differential was pretty wide. We were thinking perhaps he has a muscular dystrophy or a metabolic myopathy, like a mitochondrial defect, or another biochemical metabolic disorder. And so we started off with a very broad workup. We decided to take two approaches. One was to look at his intellectual disability and work that up with doing Fragile X, comprehensive autism panel, and we also did metabolic labs to work up a possible metabolic myopathy. And that workup was a non-diagnostic. We did find a variant of uncertain significance in a gene associated with developmental delay in autism, but it ended up being maternally inherited and was ultimately determined that it was not contributory to his phenotype. So finally, after this initial go around, we decided to order a neuromuscular disorders panel, where we were able to diagnose him with a dysferlinopathy after we found that he was a compound heterozygote for autosomal recessive pathogenic variants, pathogenic and likely pathogenic variants in the DYSF gene. One of these he inherited from his mother, which we know, and his father, who was not available for testing. We can presume that the other variant was inherited from him. So based on this, we were able to finally give the patient and his mother a diagnosis as to a name for why he had the hyper-CKemia and the myopathy, and we were able to give him recommendations to help direct his care. The first was a referral to cardiology, because from previous studies, we knew that patients with dysferlinopathy can have left ventricular dysfunction. So we referred him to cardiology for a baseline exam. And we also referred him to pulmonology, as these patients can have restrictive lung disease. And we advised that he continue to follow with them, in addition to neurology, every 2 to 3 years. And then we also were able to give him a sense of prognosis that that oftentimes these patients, by the time they're their 40s or 50s, will need walking aids, so canes or a walker or a wheelchair, and we advised to be able, so that he can prolong his mobility as much as possible, we referred him to physical therapy. So the second patient was a 40-year-old female with well-controlled non-insulin dependent diabetes. When I saw her, she had an A1C of 6.8, and she was referred by her endocrinologist for an evaluation of maturity onset diabetes of the young, or MODY. And she had no other history that would point to insulin resistance in typical diabetic patients. So no history of hypertension, no hyperlipidemia, no obesity. She did have gestational diabetes in both of her pregnancies, which were managed with insulin, and it was after her second pregnancy that her A1C remained elevated, and so she was started on metformin and eventually also sitagliptin. And it was noted that she had marked sensitivity to sulfonylureas and would become hypoglycemic to the 60s when this medication was started. So she was just maintained on the metformin and sitagliptin. On exam, she had a normal BMI, and her exam was otherwise normal. And her family history she did have multiple family members with adult onset diabetes. Both her mother and father had diabetes, although both of them were overweight and obese. So it was hard to say if it was perhaps related to a MODY or typical diabetes type 2. So we sent off a MODY panel for her. And as I mentioned before, not everything is black and white. We actually found a variant of uncertain significance in GCK, which is a gene associated with adult autosomal dominant MODY. But when we dug into this variant a little bit deeper, we saw that this variant is not observed in large population cohorts. Computer analysis supports that this variant would have a deleterious effect on protein function. And most importantly, it was seen in 2 families with a reported MODY phenotype. And we also did our own literature search and found another paper that had been recently published in JAMA, which reported 4 more individuals with a MODY phenotype with the same variant. So based on all of this information and based on her clinical phenotype, we were comfortable with diagnosing her with GCK MODY. And so my recommendations to her were to discuss with her endocrinologist about stopping metformin and sitagliptin, because we know in GCK MODY patients that regardless of the therapeutics that they're on, their A1C is going to remain unchanged. And they also have a very low risk for end organ damage that are seen in typical type 2 diabetics. For example, neuropathy and nephropathy. The one exception, though, is retinopathy. So in one study, they did see that 30% of GCK MODY patients had retinopathy compared to 14% of non-diabetic controls. So we recommended that she continue yearly dilated eye exams to surveil her for retinopathy. And of course, we counseled her on the risk of passing this down to her children and gave her screening recommendations for them. My final case is actually a case that I did not personally see, but it was a case that I found during my fellow research under the direction of Drs. Balwani and Abul Hassan. So this was a project I did within the Mount Sinai BioMe Biobank, where there's about 30,000 Mount Sinai patients that have whole exomes sequenced. And I evaluated the prevalence of 4 lysosomal storage disorders within this biobank. And I sought to identify patients with likely pathogenic or known pathogenic variants in those disorders, review their electronic medical record to determine if their symptoms were consistent with the respective genetic disorder. And I did find 6 individuals with a pathogenic variant in GLA, which is the gene associated with Fabry disease. And after looking in their charts, half of them had clinical findings that were supportive of a clinical diagnosis of Fabry disease. One particular example was a 69-year-old female who had a subdural hematoma, cardiomyopathy, renal infarcts, and cortical spokes on an eye exam. And I put a picture of a Fabry patient with one of the pathognomonic eye findings, which is corneal verticillata. And so based on this patient's exam and also her history of heart and renal disease and CVA, which you can see in Fabry patients, we determined that her history was very suggestive of Fabry disease. And so you can imagine that that having a diagnosis for this patient could potentially aid in directing her treatment, as well as diagnosing some of her other family members. So in closing, I wanted to give you some faces to put to names. These are my colleagues in the clinical genetics team. We have Dr. Mehta, who is the director of the clinical genetics division. We have Dr. Jabs, who is a renowned research physician scientist with a specialty in craniofacial disorders, and she sees, in addition to craniofacial disorder patients, she sees other patients in her clinic. We have Dr. Lozana, who has a specialty clinic in autism and Fragile X, Dr. Webb, who specializes in mitochondrial medicine, and then my colleague, Cassie Minces, who is our newest member of our team, who has an interest in endocrinology and is also the director of our new telegenetics program. And our team would not be complete without our genetic counselors, our wonderful Lisa, Isha, and Veronica, who help us counsel and talk with our patients about their results. So if after this talk you're thinking there are a couple of patients you have in mind that would warrant further workup, we're happy to see them. The easiest way to get them to us is to place an order in Epic for a consult to medical genetics, and you can have your patient call us. The number there, we're located in Atranberg on the first floor. And I wanted to close that we have a new telegenetics expanded access initiative that's being led by Dr. Mintz. So feel free to email her if this is of interest to you or your clinic. Thank you very much, and I'm happy to answer questions.